Hi, everyone. Thank you for being here. Thanks for inviting me. It's wonderful to see familiar faces of patients that I know, and I've had the pleasure of working with Stephanie for a long time, and great to see her again, and Mary, and all these. It's a happy reunion. So I'm Beth Doerfler. I'm one of the dietitians at Northwestern. I work in GI specifically, so I have 3 boys at home, so I joke that it's all bowels all the time for me, whether it's at work or at home. But really, I want to use this time for questions that you have. So feel free to, I have a few things I wanted to talk about today, but I'll make sure that we have time for questions because I want you to be able to ask whatever you want. Supplement questions, crazy things you've seen on Instagram. I'm happy to take it all. It helps me learn too. So I'm thrilled that later today you guys are going to be hearing from Dr. Khanna, who's going to be talking about some of the GI fallout or the GI complications of scleroderma, because we really see a lot of that as well. And many of the times what I'm doing with nutrition is, as you know, this is a very sophisticated disease. And when we're thinking about GI and nutrition, we're thinking about many sophisticated things. Like, we want to keep our patients well nourished. We want them to have good muscle mass. And then when you have symptoms associated with GI complications of scleroderma, how do we target and manage those symptoms? Whether it's reflux or delayed stomach emptying or bloating or diarrhea or constipation. So we're going to talk a little bit about some of the common symptoms, and I know Dr. Khanna is going to talk to you a little bit about why scleroderma produces those symptoms and sort of how you can medically manage it. I want to talk to you a little bit about, if we're using nutrition, how can we use nutrition to sort of manage some of those symptoms. So the first thing that I want to plant seeds that my first lens when I'm working with clients is I want to make sure that we're sort of assessing your nutritional status. And nutritional status is a little different than nutritional risk. Your status means, like, can you exercise the way that you want, sort of taking out things like maybe interstitial lung disease and so forth, but do you feel like you have the stamina? Have you lost weight, and do you feel like you've lost muscle in that process? Scleroderma can sort of directly impact muscle growth, and so that's something that we consider. And then, of course, are you eating less? Is that why you feel like you can't exercise the way you want to? So these are some important considerations. Let me go back to say that if you specifically have lost more than about 10% of your body weight in a fast chunk of time, like 6 months or less, that should be a red flag to your provider that you need to see a dietitian, or that we need to have sort of a more in-depth discussion about your nutrition and ways to sort of fix that and get you back up to your fighting weight. So I want to focus on a few GI conditions. We're going to start with the upper esophagus. So one of the symptoms that many of you are probably navigating through is difficulty swallowing. And I think Dr. Richardson did such a great job of sort of distinguishing, like, do you feel like you can't get the food into a ball that can get sort of out of the mouth, or do you feel like your swallowing issues are sort of here in your esophagus? And this is sort of the area that I want to target. For what it's worth, I have a very badly behaving esophagus too, so I really understand the sensation that my patients talk to me about with difficulty swallowing. We know that people with scleroderma, as many as 90% of people with scleroderma have GI symptoms. It's sort of one of the most common consequences of having scleroderma, that the smooth muscle of the intestines, esophagus, stomach, lower intestine, just doesn't contract the way that it should. So I want to talk about reflux, because reflux is a really important thing that many of you are navigating. We do a lot of research on reflux in our division. Traditionally, we'll talk about some of the traditional advice. Many of you may have been told, avoid acidic foods, avoid spicy foods. We're sort of pulling back on that recommendation, because what we found is that removing those things, many people still have reflux. So we have to sort of figure out other ways to still target the symptoms without really limiting your diet. Elevating your head of bed is a really important thing, and it's not an easy thing to do. You can't just prop yourself up with pillows. That, you end up falling down at some point in the night, or you sort of are scrunched up. There are different wedge pillows. There's I don't have any affiliation with these companies, but there's a pillow called a Medcline pillow, which allows you to sort of lie on your left side, and there's like a little spot for your arm so you're not crushing your shoulder. There's been studies on the Medcline pillow specifically for people with reflux. I've tried to write letters for people to get like a special bed that they can, adjust the head of their bed. So there's a couple of things that I think are really important to do. Wearing really tight-fitting clothing can be an issue for reflux because it increases the intra-abdominal pressure. So that's something that, wearing tight pantyhose or tight jeans may be something that really exacerbates your reflux. Many of you get the advice to eat small, frequent meals, and I think that that's important as a way to sort of get calories. But remember that when you have scleroderma, the bottom of your esophagus sort of stays loosey-goosey all the time. And when you eat, you get further relaxation of the bottom of the esophagus. So if you're a person who sort of grazes all day long, it potentially sets the stage for a lot of reflux all day long because you always have something in there that sort of comes up. Number one goal, though, is we got to get you nourished. So if you've lost weight and you're eating all day long because you get full fast and you need those calories, that is my priority. Your doctor might recommend a proton pump inhibitor or an acid-blocking medicine, and those get sort of some bad press, but they really do have a very good safety profile. And what I would say about those medications is they're really important for people with scleroderma because your esophagus doesn't always empty the way that it should. It doesn't always clear itself well. That combined with stuff kind of coming back up can really sort of be irritating. So there's something that we measure in GI called a transient lower esophageal relaxation, or TLESR. And that just means like when you eat, it's normal. Your esophagus should open up a little bit. In scleroderma, of course, your esophagus kind of stays open very often. So the original advice was we want you to avoid some of these foods. But now we're really trying to personalize that. Because, like I said, what we found is people will take mince out of their diet or they'll take tomatoes out and they're saying, boy, I still have reflux. I will say that I think concentrated versions of acidic foods, like, say, tomato sauce, is a very different reflux ballgame for us than maybe something like fresh tomato slices. It may be natural for you to have like reflux or heartburn symptoms after you have orange juice, but you may feel fine having lemon wedges in your water. So I want to give you permission to put some of those acidic fruits back in your diet if they don't bother you. Like your symptoms really are the thing that drives sort of what we would tell you to do or not to do. You're not endangering yourself because you're having slices of fresh tomato on, say, a turkey sandwich. The other thing that's really important is that we've noticed sort of a Mediterranean style of eating seems to be very helpful at reducing inflammation in the gut and also in the esophagus. So we'll talk a little bit about that. So the Mediterranean diet is really more than just Mediterranean flavors. It really is a diet pattern of eating that prioritizes anti-inflammatory foods like olive oil, nuts, seeds, fruits, and vegetables. Now, many of our patients can eat those foods, but need them to be texture modified. So, for example, nuts may be difficult for some of us to swallow, but having a pureed almond butter or peanut butter is easy to swallow. Maybe if it's too sticky, then we mix it in protein shakes or we might put it in like a hot cereal. So there's all sort of hacks that we can do to allow you to sort of get those anti-inflammatory foods in, but in a very texture modified way. And it matters when we talk about inflammation. So, one of my sort of gripes, I guess, and it's probably shared by many of you, is that so much of what we know about nutrition and how it can be helpful, we need directly applied to our scleroderma patients to see how does it affect outcomes in scleroderma. In heart disease, though, as Dr. Richardson was talking a little bit about, inflammation that affects the blood vessels may affect us in other ways. When it comes to heart disease, early on, about 10 years ago, we had some really great large clinical trials come out in Europe showing that at least 25% upwards to maybe a third of people who had heart disease, diabetes, some of these very pro-inflammatory conditions, when they received a Mediterranean diet over a standard low-fat diet, about a third of them had a substantial or had no new cardiovascular events. So this really showed that some of these foods in the Mediterranean diet, like olive oil and nuts and plant-based fats, were directly anti-inflammatory. One thing that's interesting, like a small little nerdy dietitian thing that I was really excited about in this study, so people got randomized. One group got extra olive oil, one group got extra nuts, and one group was the control group and got a standard low-fat diet. The olive oil group was actually drinking 4 tablespoons of olive oil a day, which, you don't have to drink it. You can drizzle it on your food. You can add it to soups. But what's interesting about olive oil, unlike any of the other fats, is that olive oil has phenolic compounds. Phenols are things that are in green tea and raspberries and other things, and they are very protective to esophageal tissue. They also sort of emulsify some of the gases in our gut that can sometimes cause bacterial overgrowth. So there's all sorts of health benefits to phenols. They happen to be in red wine too, but they're really dense in olive oil. So there may be some reasons why that's one of the foods that makes the Mediterranean diet so helpful. I realize this isn't scleroderma, but in our patients with Crohn's disease, there was a really big push to see if, and Crohn's is an autoimmune condition that ulcerates and affects the intestines. There was a big push to see how the Mediterranean diet compared or controlled inflammation in people with Crohn's disease compared to a very strict diet called the SED diet, which gives people no grains. And it's a very, very strict sort of punishing diet approach that was originally thought to be sort of helpful for people with Crohn's. And they looked at symptoms. That's sort of the first bulk there. They looked at what you see as fecal calprotectin. That's sort of a marker of stool inflammation. And then they looked at CRP, which is sort of body inflammation. Your doctors may look at that in you as well. And what they found is that after 12 weeks on the diet, people who were in the Mediterranean arm actually did just as well as the people that were in this really strict sort of punishing diet approach. So now in Crohn's disease and other autoimmune GI conditions, we're really trying to recommend a Mediterranean style of eating. This is a sample menu that actually was used in the study. And there's a couple of things that I would highlight. Now, some of you may look at this and think, oh, that's too high fiber for me. That's fine. We can always modify the fiber. You don't have to have celery. You could have cooked carrots. You could do some roasted, smashed up broccoli. So there's lots of ways that when you look at a menu for something and you see a vegetable and you think, I can't eat that vegetable, swap it out for something else. Fruits and vegetables have a lot of competitive crossover nutrients. But some other highlights about the diet is it's low in refined sugars, so it doesn't mean you can't have sugar, but that, the traditional American approach is that we have a tendency to do sugars sort of multiple times throughout the day. And here's another interesting thing. The diet actually contains some wheat and some dairy. So one thing I don't really have slides on just yet, I have a little bit of this in some of the slides to come, but many times patients will say, should I be avoiding gluten? Should I be avoiding dairy? Should I be avoiding this food? Because we've sort of been made to feel like there's some foods that really sort of weaken our immune system or are really, sort of driving our scleroderma in some ways. One, we need more research on that. But number two, what I would say is that while certainly I don't want to sort of pepper some of you with so much gluten and so much dairy, I think that we can easily fit that into your diet in some ways without rocking the boat. So for many patients who have a lot of lower GI symptoms, we do low gluten and we do sort of lactose-free dairy. We'll talk about that in a few slides to come. Just a quick primer on some of the healthy fats. Anything that's plant-based is really great for your blood vessels, but only the olive oil really has those phenolic compounds. Nuts and nut butters have that too. One other thing I want to say about reflux before we move on to sort of the lower GI symptoms. There is it's over the counter in air quotes because you can't really buy it in a drugstore. You have to buy it online. And if you see a GI doctor, talk to your GI doctor about it, talk to your rheumatologist about it, your primary care doctor. If you are a person who gets reflux, and let's say you're on reflux meds, but you still get some breakthrough symptoms, there is an over-the-counter product called an alginate. And there's 2 brand names here. There's probably, if you look on Amazon, there's probably 20 different brand names. Alginates are usually like a little sodium bicarbonate or potassium bicarbonate, like a little baking soda, and they have an algae extract in them. When the algae extract mixes with your digestive juices, it forms this foam, sort of depicted as the little bubbles there. Because after we eat, we get like a little pocket of acid and digestive juices that sit on top of the food. That's normal. That happens for everybody. But when we belch after meals or we have reflux after meals, it's probably that acid pocket that is coming up into the esophagus and really bugging us. It may not be the chemistry of what you're eating. It may have a lot to do with your anatomy. And so alginates are helpful because they're not systemically absorbed. They sort of work locally in the gut, and they only work for a little bit. They only work for about 3 to 4 hours, and then they break apart and go away. They really don't have drug interactions, but before you layer something like this on, we always want you to talk with your GI doctor because they're so good at sort of making this foam that we would want to make sure that they don't absorb or sort of prevent you from absorbing other helpful medications that you might take at meal times. But these can be very important things to layer on at night if you think, boy, I'm doing okay during the day when I'm upright, but as soon as I lie down, I really am having a lot of breakthrough symptoms. So Reflux Gourmet is one that's made in Napa. It's got like a salted caramel flavor. It's really, beautiful. Tastes good. It's sort of a thick gel-like medication. Gaviscon Advanced comes from the UK. There's other brands as well. So let's talk a little bit about the lower GI tract. So many of you have gastroparesis or delayed gastric emptying. Some of you might have IBS. Because of the delayed emptying in the stomach and the small bowel, a very common side effect is that our patients develop small intestinal bacterial overgrowth. So if you are a patient who burps a lot, feels like your stomach blows up after meals, you feel like you just have a lot of gas and bloating and just really a lot of belly tenderness that is, of course, made worse with eating, that can be a sign that things are slow moving. And if they're slow moving, it's not that you're eating the wrong foods necessarily, it's that the foods can ferment with your gut bacteria. And your GI doctor might do a breath test where they look to see, are you making too much hydrogen or methane or carbon dioxide? So that would be something that you want to talk with your rheumatologist about seeing a GI if you feel like these lower GI symptoms are really bad. Dr. Khanna will probably talk to you more about that today. Like, don't try to just suck it up. If you don't feel well, make sure that you are talking about it and getting tested for it. If we're going to try to intervene with that nutritionally, we borrow from what we do with IBS patients to try to treat bloating, and I want to introduce that to you. It's something called a low FODMAP diet. Now, some of you may have done this on your own. Some of you may have read about it. I'm going to put some sort of caution lights out about this diet. If you look it up online and you look at the eat, don't eat list, your head will swell like, oh my God, this is impossible. I cannot do this. Where our research is moving on the low FODMAP diet is a modified or sort of a FODMAP light. I want you to cut corners on this diet, and I'm going to sort of talk to you about how to do that. What we're seeing is that even in IBS, a modified or sort of a gentle low FODMAP really gets us the same sort of bloating reduction as the full diet without, removing so many things and then having to add things back in. It has traditionally been studied in IBS, lots of research on it in Crohn's, a few papers looking at it in scleroderma. A few years ago, my colleagues and I did a trial with our scleroderma patients. Some of you were kind enough to participate, called the MNT PASS study. I'll show you some of the data from that. We did some modified low FODMAP approaches with our patients who had a lot of GI symptoms, so I'll show you that in a few slides. But a few things to remember. This is supposed to be sort of a guided eliminate. It's not like you're eliminating these foods and then you stay eliminated. The goal is to sort of reduce some things that we think are highly fermentable or highly gas-forming. See if you feel better. If you don't feel better, the restriction doesn't make sense. If you do feel better, then we want to start to add some things back in to see what can we get away with. It is a substitution diet. It is not like an eliminate and avoid diet. In IBS, we know that diet and medicine and behavioral therapy can be really helpful for our patients, and I think our scleroderma patients benefit from that as well. Just a quick note that the low FODMAP diet does seem to improve symptoms of bloating. Specifically, the last point there in the bottom, some new studies, one of the dings on the low FODMAP diet is people worry, will it hurt your gut bacteria? We know that in scleroderma, gut bacteria is sort of off. It's different than people who don't have scleroderma, and that may be an opportunity for interventions down the line. It doesn't appear that the low FODMAP diet, specifically in patients with scleroderma, negatively affects your gut bacteria. That's sort of a new finding, so that's a positive thing. One thing that I often talk about when I'm working with my colleagues is that if we're going to do diet therapy with any of our patients, we really want them to see a dietitian who sort of is used to doing some of these diets, because when we talk about when we ask patients, hey, if you got diet advice from your doctor and you didn't see a dietitian, what did you think about it? And people usually say, oh, I stayed restricted for too long. I felt like it wasn't personalized enough. I feel like I didn't know what I needed to eat. So also, if you're not working with someone, I'll show you at sort of the end of the slide how you can get connected with some. So it's really easy in nutrition to have a don't eat this mentality, and what I want to do with the next few slides specific to the low FODMAP diet is show you the do behaviors, or sort of these are do foods you can have. So sometimes when people go on a low FODMAP diet, they really cut down on their fiber. And what I'm going to show you in scleroderma, I don't want you to feel that you need to have a low fiber diet, but often people benefit from fiber modified, like we cook it, we chop it, we puree it, we blend it, because it's either too hard to swallow or it sits here for too long, and we want the benefits of it, but we need a little texture help. So foods that are technically low FODMAP foods but are very good sources of fiber for us are things like berries, kiwi, zucchini, eggplant, tomatoes. Again, maybe you can't do a spicy tomato sauce with garlic, but you could probably do a few slices of fresh tomato. Citrus is another thing. If you have reflux, you probably don't have, but you can definitely try some of it if you want. Kiwi is the belle of the ball these days. I'll tell you more about that in a few slides, but there have been some great studies showing that kiwi works as well as Metamucil to help people have bowel movement spontaneously without the gas and the bloating. In that clinical trial, 2 kiwi a day, whether golden or green, was the therapeutic dose. So these are foods that you might think you can't have if you're on a low FODMAP diet, and what I would say is you can have them, but portion sizes matter. So things like avocado, Brussels sprouts, squash, almonds, these are really great foods for you, and you can have them in a texture modified way if you need. But having, a whole avocado because it's easy to swallow might make you feel gassy. You may have to stick with sort of a half at a time, go back later and do the other half. Gluten is something that is not pro-inflammatory as much as it's highly fermentable. Our gut bacteria love a special fiber in gluten called a fructan. Fructans also happen to be in garlic and onions. They're good for us. I mean, when we make gas because we're sort of fermenting these things, it's not bad for us, but it doesn't make us feel comfortable. So what I wanted to focus on is some of the things that are technically whole grains, like quinoa and oats, even sprouting wheat, like buying breads that have sprouted wheat, can make it less fermentable. Now, if you personally are someone who knows that you do well with very little gluten in your diet, I fully support that. There's sort of a spectrum here. Some of our patients find that they can do little bits of gluten, maybe a slice of sourdough bread, and that's sort of where they tap out. Other people feel like they can do more of it, and some of my patients are like, I'm really best if I do none. So I think there's an acceptable range, and we have to find what's right for you. Dairy's the other one. Dairy sort of gets a bad reputation, I would say undeservingly. Yes, there's dairy and protein shakes that maybe have a lot of emulsifiers, sugars, and artificial ingredients, but things like an ounce of cheese or a little bit of yogurt or kefir actually doesn't have a lot of preservatives and is very low in lactose, which is the fermentable sugar. So if you are limiting dairy and you are not sure how you do with it, you have my permission to try a little bit. And I would probably tell you to start with maybe an ounce of cheese, maybe some goat's cheese or a little Swiss cheese or something that doesn't have a lot of lactose, and see how you do. Again, if you don't think you feel well, we honor that. Seeds are excellent sources of protein. A quarter cup of pumpkin seeds has 9 grams of protein, but a cup of pumpkin seeds is a lot of chewing. Pumpkin butter is a beautiful thin texture that has all the benefits of pumpkin seeds in a fiber modified texture. So whether it's cashew butter or macadamia nut butter or peanut butter, if it's too sticky, mix it in with a hot cereal, cream of rice, oatmeal, grits, something like that, put it in a smoothie, and then you can swallow it much better. So just a couple of last things I'll say about this, and we're going to talk about muscle mass before we wrap up. We really want you to see someone who sort of knows this diet. If you can't access a dietitian, there are some really great websites here that you can check out. If you're a person who's prone to constipation, things like kiwi, prunes, mango have all been studied specifically to help with spontaneous bowel movements, with kiwi being the winner. It seems to help the most with the least amount of side effects. Last thing I'll say on this texture before we talk about muscle is just that in studies with people who had gastroparesis, we found that reducing the particle size, it's sort of like a flashy way of saying we cooked it, we chopped it, we blended it. Probably the things that many of you are doing. But what we did see is that people didn't have to stay away from so many fruits and vegetables when they blended or chopped up the particle size. So a little bit on muscle mass. We need more scleroderma research for muscle specifically, because we don't know what we don't know about how you can build muscle and lose muscle with scleroderma like we do with just a natural aging population. But once we hit our 40s, we lose 5 to 7% of our muscle mass anyways from age-related muscle loss. So by the time we hit our 50s, 60s, 70s, we're seeing a lot less muscle than our 30-year-old bodies. If you have inflammation, that's going to make that worse. What we're really interested in is something called sarcopenia. Sarcopenia is muscle loss that is such a big deal that it impacts your ability to sort of move and function well. It also puts you at a higher risk of falls. About 5 or 6 years ago, my colleague and I, along with some of our GI doctors, Dr. Hinchcliffe, who used to be at Northwestern, did a small study. We had a tiny, tiny grant to look at what we called MNT PASS, which is Medical Nutrition Therapy PASS. And what we wanted to do was look at muscle mass in our patients and then see if we could do some things with their diet to sort of improve their nutritional status. What we found is that some of the tinkering we did with diet, and we did some low FODMAP stuff, we brought in some olive oil on foods. We really wanted to sort of fluff people's calories, and we wanted to try to target some of the GI symptoms. The study was 6 weeks. We did a total body DEXA. So when you're getting bone density, they're just looking at your hips and your spine. I'm hoping total body DEXAs are available clinically. Right now, they're not. But a total body DEXA can get you muscle mass as well as, all throughout your body. And interestingly, what we found is that in our study, our patients were able to increase their calories by about 200 more per day with just some minor sort of modifications. We also noticed that our patients had statistically significant improvements in appendicular lean mass, which means the muscle mass in their legs and the muscle mass in their arms grew in only 6 weeks. What's interesting about that is we did no exercise intervention in this trial. We really just focused on getting people more calories. And what we found is that that extra calorie intake probably benefited their ability to be more active and more functional. So we do see that muscle mass growth is possible, but we need to optimize the other parts of your nutrition. You have some of these slides. I'll sort of jump over the protein thing, but what I do want to sort of highlight here is that we do see plant-based proteins actually are just, so if we're thinking about building muscle mass, one, we got to make sure you have enough calories. You can't build muscle if you don't have enough calories. We need a little bit more protein. We don't need to flood you with protein, but we need a little more protein. Proteins are hard to swallow sometimes. So sometimes people can't do chicken and they can't do, you know, eggs and steak and things like that. Fine. We want to think about maybe a protein powder or some other clever ways to get protein, which is sort of why I want to see, can you tolerate dairy, to, to get some of these things into your diet. In studies among people looking to build muscle mass who did protein supplementation, soy and pea protein were actually just as good as dairy-based protein at helping to build muscle mass. So we have a lot of choices of things that we can use. So just to summarize a few things that I like to tell people, then we can open it up for question. There's a little bit of a push everywhere to get more plants in your diet because we know plants have a lot of antioxidants. They can fight inflammation. The problem in scleroderma is that you get full fast and plants can take up a lot of space. So we really need to, I want more plants in your diet, but I also want them with other high-calorie items like, if we're going to blend some vegetable soup, I want some olive oil, maybe a little bit of, cheese or low-fat dairy sort of mixed in to add like a creamy component. Most Americans get too much protein, so we tell the rest of America limit the protein to about 1/3 of your plate. It's okay if you're eating small amounts of protein. What matters more is that over the course of the day that you specifically accumulate that protein. A very understudied area but that is gaining a lot of momentum. We're studying it quite a bit in our Crohn's patients. Dr. Khanna published a paper within the last year looking at that this is potentially an area of important study for us in scleroderma, is sort of the role of the gut bacteria and how that might modify or modulate inflammation. There are some things that help our gut bacteria, like eating more produce. There are some things that hurt our gut bacteria, like these emulsifiers specifically. So emulsifiers are things that are added to ice creams and coffee creams and, deli meats and store-bought, goodies that have a tendency, that are intended to sort of hold the food's shape. The problem is these emulsifiers, they also make things shelf stable. The emulsifiers are very good at adhering to our intestinal lining, and maybe making bacteria adhere to those intestinal cells too. So that's sort of one of the areas that's being studied. How we manipulate that, how that impacts scleroderma, we still need more research. In our Crohn's patients, however, we're saying these are some that you should modify. So it doesn't mean you can't have packaged foods, but be on the lookout for things you can't pronounce. That's a good clue that is something that is maybe not a stabilizer for you. Interesting studies on the American Gut Project, which is sort of an individual thing looking at what is normal gut bacteria, what is abnormal gut bacteria. It's a bunch of independent scientists looked at, what are some things that really help promote good bacterial diversity. And people who had the best bacterial diversity had about 30 different plants in a week. Now, that sounds like a lot. But if you think about times 7 days, that's about 5 plants in a day. So if you can start your day with oatmeal and you do maybe some blueberries added in there, maybe a tablespoon of walnut butter or almond butter, that's 3 of your 5 in the course of the day. Now, there's room that we could probably do more, but just to sort of put it in context that it may not seem as daunting as it appears. We don't worry about fruit. I want to make a quick comment about sugar. Some people feel like they should be limiting fruit. Fruit and vegetables have a lot of crossover nutrition. If you can eat fruit better than you can swallow vegetables, do it. When you look at sources of sugar in the American diet, fruit's not even listed here. It makes up less than 1% of the sugar in the American diet. So bananas are not the cause of obesity in the U.S. We're not eating too many bananas. Eat the fruit that you want, and if it's an easy-to-swallow template for protein foods like cheese or, peanut butter or something like that, go for it. The other thing I will say is that I have a tendency to think about colors. So I often will encourage my patients, whether it's fruits and vegetables, something red, something yellow, maybe something green in the course of the day. Then you're getting that spectrum of antioxidants. The last thing I'll say before we open it up to questions here is that I do think it can be helpful to try to schedule meals. If you don't have a big appetite, it's really easy to get to 2 in the afternoon and be like, oh, wow, I haven't eaten anything, and now I'm sort of behind the 8 ball. I can't possibly make up these calories. So see if, even if it's starting things early in the day with liquids, let's see if we can, try to get you to sort of dinner time having already eaten a decent amount. The benefit of that, too, is when you have gravity on your side, you have much better intestinal emptying. If you are not in the Chicago area or you don't have a team at Northwestern and you want to work with a dietitian locally, you can go to eatright.org, which is the Academy of Nutrition and Dietetics. You can put in the zip code that you're in, you can filter by specialty, and you can get dietitians that are in your area that you can work with. So with that, before lunch, I'd love to answer questions, whether they're related to this or not.
Gotta be food questions.
Right, got to be nutrition questions at least, but it could be any nutrition question.
Here, we're going to use the mic so y'all can hear the questions. Go ahead.
Hey, so my question was in regards to, you brought up using proton pump inhibitors for treating GERD and scleroderma. I was curious, what has been the advancement in potassium competitive acid blockers? I know that there was a lot of news around that in like 2018 and early 2022. Are those coming on the horizon and available?
Yeah, I mean, I would tell you, so just to repeat the question, there's another group of medication called PCABs that are thought to have a better safety profile than PPIs, and they are available in Japan, not quite ready for prime time here in the U.S. What I have heard from my physician colleagues that do a lot of PPI research is that we're at least 3 to 5 years away from being able to get our hands on those.
Okay, thank you.
Yeah.
What do you think about like nutritional shakes?
Funny, I love shakes. That one.
That's the question.
So yeah, the question, thanks, Steph. So the question is about nutritional shakes. Nutritional shakes are really important, whether they are pre-made or homemade, because liquids don't require esophageal motility to empty. So if you really struggle with swallowing, liquids are a really important way to make up calories. The other thing, there was a great study that was done years ago called the MedPass program, where they had people take little shots of a nutritional shake with their medications or vitamins. So I think sometimes we make people feel like they have to drink the shake all at once. If you get 2 to 3 ounces in the morning, 2 to 3 ounces in the afternoon, 2 to 3 ounces in the evening, you've accumulated a whole shake. So, I don't mind which shake you do. I have a tendency to recommend ones that don't have a lot of emulsifiers and a lot of sugar. But if you're a person who can tolerate yogurt, a half a cup of Greek yogurt is really the same as a scoop of protein powder. So if you're making your own protein shake with a half a cup of yogurt, a little bit of frozen fruit, maybe some peanut butter, that's really competitive with what you might buy. But you have to think about feasibility. If you can't, I realize that for many people, cooking and blending is not always an option, and we need some ready-to-drink ones. So, yes.
How do you feel about gummies, supplements that contain fruits and vegetables?
Great question. So the question is about some of these powdered pills, gummies that have fruit and vegetable extracts. So there is an organization that is a fantastic resource commenting on supplements called Consumer Labs. And it's a membership thing. I don't work for Consumer Labs, but it's an independent, it's a bunch of doctors and researchers who scrutinize supplements to look at things like heavy metals. Do they deliver what they say they deliver? What's the data? Is it worth your time and money? They just reviewed green powders and products like Juice Plus and sort of all these capsules. So the long and the short of it is that green powders are problematic because they often are a source of heavy metals. You would actually do better to cook a little bit of baby spinach, maybe puree it, make ice cubes out of it, and then figure out how to get it into a soup or a smoothie. You'll get more antioxidants and less lead. Other gummies like Juice Plus, and there's a few other brands, those passed their lead tests, but in reality probably don't deliver nearly as many antioxidants as a half a cup of juice or, you know, some frozen berries that you might blend. So I'm not opposed to them, but I think they're a lot of money and they don't deliver as much nutritional bang for your buck.
Hi. My wife was seeing a nutritionist prior to her scleroderma diagnosis, and the nutritionist recommended the ALCAT testing and the blood testing.
Yes.
Do you have an opinion on that?
Yeah.
Just kind of whether that's effective? Because she's been pretty, they say, dedicated to some of the recommendations, and I'm just curious if you think that that's an effective diagnostic process.
Yeah, in short, no, it's not. But the backstory to that is this. We know that our patients have a lot of food intolerances, and some of that has very little to do with food chemistry. Some of it is because our guts are slow when we have scleroderma, and no matter what it is, your food is more prone to fermentation than someone who has normal motility. So even if you're eating all the right chemistry, you can still be prone to fermentation. So that's one thing. The other thing about those tests, and we see it in our IBS patients a lot, we know food sensitivities have a lot to do with feeling unwell, but those tests measure tolerance, meaning your immune system has seen that protein before. And so what that test sometimes tells you is it makes it look like you are reactive to foods that have actually been in your diet. What I see a lot is that people will have that testing done, they'll remove those foods, and now they have a very limited restricted diet, and they're at risk of developing sort of an avoidant restrictive pattern of eating, which is natural. You know, you're trying to do everything you can to make yourself well. I totally get it. But we try to not recommend those tests, or for people who have had them that say, Beth, I don't care what you think. Like, this test said I'm positive to eggs and I don't feel good eating eggs. Totally honor that. But then we need to say, okay, well, if you're limiting that protein source, then we got to come up with these other protein sources that are probably fine for your immune system and allow you to get the sort of the nutritional job done. Oh, sorry.
Hi. I heard about the people who has scleroderma. They said that red meat is not good. That is true?
So the question is red meat good or bad for people with scleroderma? So in short, red meat is okay. It's fine for you to have. Red meat is very complicated to digest. It's a sophisticated protein, and it's high in fat. And so red meat sits for a little bit longer. And so but absolutely my patients don't feel as well eating red meat as if they're eating, you know, leaner proteins that are faster digesting, like fish and tofu and, you know, chicken. From a heart disease perspective, you could actually never have red meat and it would be fine for you. You know, red meat definitely increases heart disease risk. The question is, like, can you get away with it? You know, can you have it once a week and sort of stay neutral with your heart disease risk? And you can. So in short, I would say if you love red meat and you want it, eat it. You may have to texture modify it, have it at lunch instead of dinner so you've got enough time for emptying. But if you don't think that there's no reason to have it if it's not part of your diet and if it makes you feel unwell. Yes.
What is your opinion on eggs and cholesterol?
Yeah. Important question about eggs and cholesterol. What's the verdict? So the American Heart Association says if you don't have heart disease, one whole egg a day is totally fine. So the egg yolk is where the cholesterol and the fat is. The white is just all protein, no fat. So what I like I'm definitely a dietitian that likes to eat, so what I like to do is one egg with a bunch of egg whites, then you get sort of the flavor of the whole egg, but you get the added protein without all the added fat. For people who have heart disease, the recommendation is about 3 egg yolks a week. So you could have egg whites every day, but sort of 3 egg yolks a week. And you had a question, sir?
This is more about me being the husband of a person with scleroderma
Fair.
and our nutrition.
Yeah.
This specifically goes to proteins. For myself, and I do a lot of the cooking.
You're the head chef.
Sometimes, yeah. I work a weird schedule, and when I'm off, and I do a lot of cooking then. But I follow what is kind of like a macro diet.
Yep.
Okay, I do like 40% protein, 30-30 is what I do. And so when I'm cooking and preparing meals for that, you mentioned protein and loss of muscle mass and everything, but is there a cutoff? Am I driving her protein levels too high or anything like that whenever I prepare meals like that? For example, even with oatmeal, I'll throw half a scoop of whey protein in or something like that.
It's a great idea.
But I don't know if I'm driving her protein levels too high or something.
It's a great question. Okay, so a couple of things to consider. Yes, please.
Well, because then I also, yes, half, and I can only get half of my protein every day of what I'm supposed to get.
Yeah.
So he's not driving my protein.
Yeah, it's such a fantastic comment, and I was going to say that in my experience, most of my patients are sort of their own rate limiting factor. They can only eat so much. They're not going to get excessive protein because they get full fast and sort of little bits here, little bits there. In our patients, we are more often than not looking to see if we can sort of get to the total we need to sort of, through accumulating it throughout the day. Layering protein in is a very effective technique for people that get full really fast and sort of can only do so much at once. It is important to say, if you are a patient with kidney disease, then we need to sort of really be personalized with the amount of protein that we recommend for you. You don't need to be low protein because that's sort of a little bit of an old advice that if you have kidney involvement that we need to go low protein. If we undercut you too much, then your body just uses its muscle for protein, and then you're sort of back where you were before. So there is a sweet spot, and I would say that for most people, if they're somewhere, certainly I look around and I see some of our smaller framed individuals here that probably would be fine with 50 grams of protein a day. Some of our other patients might really need more, like 80. So I would say if you're a person that struggles with protein because you can't eat that much, just throwing out an arbitrary number, I think 50 is sort of a good number to look at. And you might find that you have sort of the other way you could do it more qualitatively, I don't think you're giving too much because your wife only can eat so much. And that's sort of more often what we see. So I like to have people focusing on that layering approach. Where can you layer a little protein in at breakfast? Where can you layer a little bit in at lunch? Where can you layer a little bit in at dinner?
Can I ask what your thoughts are on a keto form of eating where it's a higher
Yeah.
fat, lower carb, for somebody that doesn't actually have to maybe bring their weight down a little bit because of cholesterol issues?
Yeah. So the question is about a ketogenic style or a keto diet. So a keto diet, just quick overview, is attempts to sort of reduce carb, or the focus for it has been on weight loss because it's sort of high fat and very, very, very low carb. As opposed to, say, a low carb diet, which might be a little higher in protein, sort of low in carb. Generally speaking, we don't recommend ketogenic diets for many reasons. One, they have a tendency to be very high in dairy-based saturated fats. I think one of the desserts that has a lot of social media attention is called like a butter bomb, and that is like a dessert where they replace the carbs with fat. So the original history of that diet was meant to manage epilepsy. And what was sort of an accidental finding is that people who were on it didn't have as much heart disease as they would expect for such a high intake. Our neurologists at Northwestern are actually studying sort of a modified keto diet for people with epilepsy. But I think the long and the short of it is that for people who are looking to lose weight, the data is overwhelmingly positive that if you can swap out some of your starchy carbohydrates with produce, fruits and vegetables, that's a much better swap. You don't net all the carbs from produce like you do from starches. We want to reduce carbs in the form of excess sugar. I would rather someone be sort of higher protein, low starch, and maybe they're getting their carbs from fruits and vegetables. I think being that low carb, like you would in a keto diet, in exchange for getting that much fat, is not good for your gut bacteria, not good for your blood vessels.
Thank you.
Yeah. Well, one more question.
Hello, my name is Desiree Story. I did do the fruit and vegetables, and I saw a drastic change in my symptoms.
Interesting.
But protein dropped. Like my muscle mass was visibly decreasing. So how do I get, what foods can I supplement for protein?
So if you don't mind if I ask you one follow-up question to that. So I love that you were doing the fruits and vegetables. Were you a little bit more vegan?
Not so, a little bit, yeah. I mean, I would try to do snacks that were vegan, vegetarian, but I mostly just wanted to focus on fruits and vegetables, juicing.
Yeah.
It was very helpful, but I didn't like the muscle mass decrease.
I think so the question is like having fruits and vegetables, and when she prioritized that, she noticed she lost her muscle mass. That's where I think it's not that the added fruit and vegetable intake made you lose your muscle mass, but that it was filling enough that you probably ended up curtailing eating other foods, protein foods, or calories. Interestingly, when we eat outside of scleroderma, when people lose weight intentionally, there is a percentage of their weight loss that always comes from muscle. So we sort of can't help it. When we lose weight, we lose some muscle. We try to mitigate that by keeping protein rich. So I would say for a young person who wants to eat more fruits and vegetables, I mean, without really knowing much about you, you may be a person that needs to be more like 60 to 80 grams of protein a day based on your age. If you think about that in 3 meals, that means you sort of need to be targeting about 20 grams of protein each meal. If you have a beautiful fresh fruit juice, you have to figure out how the protein is going to get into that juice in order for that to be more well-rounded. And it could be a protein powder. Really quickly, soy and dairy get bad reputations, but they deserve to be experimented with because soy doesn't increase the risk of breast cancer in women. We don't absorb the phytoestrogens. It's a very GI-friendly, like tofu is a very GI-friendly form of protein that's very quick. And if dairy is low lactose, some of our patients do great with, a little bit of cottage cheese. It's 15 grams for like a half a cup, or, yogurt. Now, it's not always right for everyone. That's why we really have to sort of personalize it. But if you've been avoiding dairy and soy because you think you should, it's time to test it and see what your personal sort of tolerance is to it. And with that, I promise I'm not going to be looking at what anyone is eating at lunch.
Don't worry, I chose some very healthy options.
Eat. Manja. Thank you.
There's also brownies, don't worry.